So I'm going to ask you two more questions before we move on to adjuvant therapy. What is the role of molecular testing in this setting? What is the role of ordering a BRAF mutation analysis on patients in this setting?
So
go ahead.
So
Matt,
on the patients that we're talking about now, so you mean the patients who have positive micrometastatic disease, or even just primary tumors to begin with?
Either one, deep primary tumors or somebody with stage 3 metastatic disease. What's the role of getting a BRAF mutation analysis in those patients?
I think it's not clear that information, whether they're BRAF mutant or BRAF wild type, has an impact on their prognosis. Clearly, it's important for selecting therapies, but in this patient population, you probably wouldn't be offering them BRAF-directed therapies at this point in time anyways.
So the BRAF trials that are out there are taking 2B, 2C, and above. For us, it's important in order to move the field forward. We know that the plan that has worked before is finding drugs that work in the metastatic setting that have survival advantage and bringing them at that point to the adjuvant. And clearly, targeting BRAF is a logical way to move that forward, and currently those trials are ongoing.
And I think that I would say in this patient population that has primary melanoma, that has no evidence of nodal involvement, we would not routinely get that testing, since we would not have necessarily an adjuvant trial for them. If we did have an adjuvant trial, as Dr. Hamid pointed out, then we would do it. But in patients with micrometastatic disease in the lymph nodes, so stage 3 patients, I think it's the scenario is the same there. If we have a specific indication to do it that would change our management and our adjuvant management, we would do it. Otherwise, I don't see the added cost adding benefit to the patient at this point in time.
Yeah, I think that we do it more often. There are trials, and actually there is one of the trials, or both of them, do allow a stage 3A where the metastases is greater than 1 millimeter. Now, obviously, not all sentinel nodes are greater than 1 millimeter. In fact, that's the exception. But certainly, a number of them would be still eligible for a trial that looks at either single-agent BRAF inhibitor or the combination. I think the other thing has to do with down-the-line management, and this again is also related to what the risk is. But patients who have high-risk stage 3 disease tend to relapse, and when they relapse, you can easily do the mutation analysis, but it's not always easy to get the tissue. And when someone has active metastatic disease, that information can be critical. And it can take weeks, if not a month or more, to get that data. So I think sometimes it may be, turn out not to be of use to that one patient, but I think broadly it gives us an ability to go back and treat those patients much more rapidly, which is critical to some of them.
I think Jeff makes a good point. I think in the future, every stage 3 patient essentially should be tested so that you'll have the information in the bank. It often may have no actionable manifestations, but given that there are 2 active clinical trials, there'll probably be more trials for stage 3 resected patients. I think it's appropriate that any stage 3 patient have their tumor sent for BRAF testing. And God knows in a year or 2 it'll be BRAF NRAS, it'll be 20 genes, and then it'll be perhaps even sequenced completely.
And hopefully a year or 2 we'll have an easier way to check BRAF.
So Jeff, let me just have you follow up on that real quickly. Is there anything out there that's coming down the road soon that would give us a really good prognostic test for these patients? It would really tell us the high-risk patients who are going to relapse, because we see patients with stage 3 disease who live 10 years without any recurrence, patients with stage 3 disease that relapse in a month. So is there any test out there that's coming soon that will help us differentiate the really high-risk patients from the ones that won't relapse at all?
Well, still the best prognostic tests are looking at number of mitoses in the primary, thickness of the primary, Ki-67 staining in the primary, and the size of the disease in the node, especially the sentinel node. Because microscopic disease with 20 cells clearly will do better than someone with a 1 millimeter focus of tumor, will do better than a patient with 10 millimeters of tumor with extracapsular extension. So there's no molecular test thus far that actually does better than the standard staging tools that I know of.
So Mario, can I talk about one gene profile that's been evolving over the last year?
That's what I was looking for. Thank you.
So there is a 31 gene array that's been studied. It's kind of an offshoot of the gene analysis that was done for uveal melanoma, but they have extended it to cutaneous melanoma. So 31 gene array. It's got 28 tumor-specific genes and 3 kind of control genes. And this gene profile is, and it's an RT-PCR assay, so you do it on paraffin-embedded tissue, so you have access to that tissue. And it identifies, or it dichotomizes patients into what's called class 1 and class 2 based on the array. And the class 1s have a very good prognosis and class 2 not as good. Now, Jeff was talking about the stage 3 patients. This particular analysis is probably not very good for the stage 3 patients because most of those are class 2s anyways. The vast majority are class 2s. But and you want to say something?
The data set was for stage 1 and stage 2.
Actually, the original data set was for the entire gamut, but it was certainly biased towards the stage 1 and 2 patients. 85% were stage 1 and stage 2. So if you just look at the stage 1 and 2 patient population, it matches up very good against AJCC staging. Actually, that its prognostic information is as valuable as AJCC. The question is, what do we do with this information right now? Because it's a very small data set. It's relatively immature data, and we don't have information in terms of each AJCC substage, what the distribution of class 1 and class 2 is, and what that actually means from a prognostic perspective. Because it's pretty clear that in each substage, the class 2 means something different. They don't all do bad. They don't all do as bad.
Merrick, I challenge you to find out how to describe this data to a patient. You have a stage 1 patient with a class 2 signature. Do you image them more often? Do you have an adjuvant therapeutic that you can offer them that can change their course? Do you create more anxiety or less anxiety?
But before you're going to go offering this to patients, how many patients are we talking about?
No. I agree with you 100%. I'm not promoting it as something that we should do now. So Mario asked, what is there something in the future?
So this is a step.
Right. So this is the next step in evaluation. We're trying to push the company that makes this a kit. We're trying to push them to do the right thing, so we can evaluate this in a large.
It makes a lot of sense to have
the testing set was how many patients?
The testing set was like 250 patients.
It's not a bad number, but it obviously requires any analysis of this kind. I think needs a really good validation set.
So the difficulty is putting it into an adjuvant trial
I agree.
Going forward. It has not been
agreed 100%.
put in anything
I think
But it's something that we would want to have, obviously, and we want to do more research in this area.
To summarize this, it's an initial step. I think it's good that we're looking at other factors than just histopathological factors. But I think that the main concern, I think at the moment, is small data set, very short follow-up, and we don't know how the responses are to treatment with this. And we definitely don't know how to image these more often or less. So I think that it's an initial step to move in the right direction.
I agree, but as an initial foray into the milieu of the clinical environment, is that the high-risk stage 2 patients that are node negative, that those high-risk patients, at least we think of them as being high risk based on either thickness or ulceration, even though they're node negative, there's a certain percentage of those patients that will go on and develop recurrent disease and die. And right now we're just using thickness and ulceration, but if we could determine that the class 2 ones are the ones who we should look at them more carefully, again, we're not there yet, but it's an initial kind of entry level to try to figure out what to do with these higher risk node negative patients. I certainly wouldn't use it as a replacement for sentinel node biopsy at any stage right now. But for the node negative patients, that would be the first place that I would look for its impact.
I think it's a key area of research.